Thank you very much, dear colleagues, distinguished chairpersons. Thank you very much for inviting me. Please treat my presentation as a kind of critical appraisal of physiology in terms of PCI procedure, because so far we have no doubts that physiology used in terms of clinical decision-making, revascularized or not, there's no doubt it works. We have so much important clinical proven on that. So let's start. How does it look like? First of all, we have to remember that in the cath lab, we like to assess only epicardial arteries. But of course, the whole coronary system is consisted of rest part of vessels, and it influences the results which we receive during the procedure. The situation is stable for diagnostic phase, but as Dr. Lee already mentioned, this reactive hyperemia caused by our intervention also imply our results. We have to remember about that. Today we have in cath lab and our cath lab possibility to assess functionality of the coronary stenosis. It works very well in pre-procedural moment. But today I would like to focus my lecture on two indices. One, this is a gold standard, which is FFR, and non-hyperemic indices, mainly IFR, because the clinical data is the biggest one for this particular index. However, we can tell about a kind of class effect for other indices, but this is not the case to discuss today. Based on the results, we are able to optimize the revascularization process, choosing between optimal medical therapy, percutaneous angioplasty, or hybrid approach, percutaneous and CABG, or in a very diffused cases, CABG. So how does it look like? Of course, we need to intubate the vessel. We need to use wire, the pressure wire, and this ratio, distal to proximal, gives us the value. We know it, we like it, but we have to remember about a lot of limitations of this, very practical, but not so clear, especially in serial stenosis, in left main involvement, which we see more and more in our daily practice. I don't want to go into the detailed parameters influencing the FFR measurements. However, what is very important, for FFR, we have also data which allows us to assess side branches, which is very important in a time where we used to perform percutaneous revascularization for bifurcation lesions, not only for non-left main, but also left main. So this is a kind of superiority for non-hyperemic. So far, we don't have enough data on that. In terms of cutoff value, we all know that, especially for multivessel disease, this is 0.8, but still we have to take in our mind that in terms of 1 and 2 vessel diseases, we should be much more critical. So 0.75 means PCI. If we have more than 0.8, we shouldn't revascularize. However, please consider so-called gray zone between 0.76 and 0.79, and then the distribution of atherosclerosis, the number of diseased vessels should be taken into consideration. So if you have this gray zone result without symptoms in patients, without confirmation of ischemia, don't trust that one vessel disease should be tackled with coronary stent. For multi-vessel disease, for diabetes, then you can consider as a point for revascularization. And of course, we have 15 years old, let's say, outcome for the patients included into the DEFER study. We know that it's much better not to revascularize what shouldn't be revascularized based on FFR. This is for sure. So this diagnostic phase is not, there is no doubt. Of course, also in FAME, in multivessel disease, that was also proven that based on FFR measurements, we can select patients which should be revascularized, and effects of this revascularization is stable at least for 5 years. But if we take into consideration the meta-analysis showing how does FFR guidance works against this or versus angiographic guided approaches, so we don't see that there is a superiority of this much more sophisticated approach to deal with coronary stenosis. So if we take into consideration all of the MACEs and additional facts, we can conclude that among patients with obstructive coronary artery disease, FFR-guided revascularization did not reduce the risk of long-term adverse coronary events or the individual outcomes. However, FFR-guided revascularization was associated with fewer number of stents. So we have to keep in our mind that one of the reasons of this situation is the fact that it's very difficult to optimize PCI based on FFR because we don't have very strong, really proven cutoff criteria for that. If you look at for this particular slide, you see that the distribution of final results after stent implantation is not very narrow. It's relatively wide. However, in terms of 2 years observation, the cumulative incidence of target vessel failure is lower for patients with FFR, let's say over 0.8. So it's normal, rational that the bigger is FFR after the procedure is the better. And this slide, this paper by Johnson really show you that this is the truth. The bigger is final FFR, the better outcome of the patients. But on the other hand, we know that it's not easy to achieve these very good, very high results over 0.94 that was proposed by Nico Pils at the beginning in the era BMS, bare metal stents. We know also from the literature that not only the post-PCI FFR is important, but also we should take into consideration the pre-procedural FFR because it shows us a kind of status of microcirculation and let's say, impact of the coronary stenosis on the function of microcirculatory. So we know that below 0.71 before the revascularization works better, that it's over. So we have remember about that, and here you can appreciate that the proposed cutoff criteria was for FFR post-procedural was 0.88. So with this knowledge, we have also to take into consideration that today we have so-called serial stenosis, and in this case, at least due to the cross-talking between stenosis, we have to repeat pullback maneuver for every stent which was implanted. That very often we are very surprised with the very strange results after stent implantation. Usually we should start from the distal stent, or our other group suggests us to start with a more stenosed place. But of course, all these limitations FFR provoked a lot of authors to work how we can improve the FFR, let's say, measurements in terms of the daily practice. Here you can appreciate the summary of the paper prepared by Professor Lee and his group, that first of all, the proposal of optimal post PCI based on FFR, there was that at least 0.84 and increase of FFR more than 15%. So it means that if you, let's say, this is not very stable one FFR digits, but just let's say fluent to the individual situation. On the other hand, they propose to use so-called instantaneous FFR gradient in a unit time, which gives us possibility to find during the pullback maneuver the place which is really significant that should be treated. This is very attractive concept. The problem is it commercially already available? How it will be proven in a bigger number of patients? Anyway, very interesting approach, giving some chances for FFR to come back on the stage. On the other hand, we know, at least from this paper, that it's very important how distribution of atherosclerosis plaque occurs in an individual patient, how big development of atherosclerosis. So it's representing by syntax score, and then if you take into consideration two additional facts to the particular patient, so FFR pre-procedure and also this syntax score, you can predict that even with the angiographically good results, the final FFR will be lower. Why? Because of the atherosclerosis distribution. So we have to take into consideration. And the last proposal to, let's say, to still use FFR is a proposal of Nico Pils and Broin group from Aalst, so-called pullback pressure gradient index. It's even more complicated than the proposal of Professor Lee. However, we still have to wait for bigger number of patients tested. As far as I know, this is very meticulous and time-consuming right now without commercially available software. What do we have? Please look at the results of target FFR trial. That was a kind of proposal which is available in every single cath lab with measurements of hyperemic transient gradient, assessing and looking for focal steps, with the repetition of pullbacks after optimization with bigger balloon, just to achieve 0.9. But if you look at the results, you will see that this physiologically guided incremental optimization strategy was successful only in less than 40% of cases. So it means with FFR it's very difficult to achieve what we would like to achieve. Okay, we can optimize, but I'm afraid that without imaging we will be very busy with that. So with IFR, we have a lot of hopes that it will be better, and in terms of pre-procedural assessment we see some additional points and can say this is even better than FFR. But how does it look like in a clinical scenario? Yes, this is an index which correlates very well with FFR. We know quite well so-called cutoff criteria, which is different to FFR, but we have remember about so-called gray zone as well as for FFR. In a two big clinical trials, it was found that IFR is non-inferior to FFR, but in selection patients for procedure, not really for optimization. And these indexes, FFR and IFR, were tested in chronic coronary syndromes and acute coronary syndrome, so it correlates very well. So there is a mismatch, functional and angiographic mismatch, even using IFR after successful PCI. One of the proposals, which was already mentioned by Professor Lee, this is a time of measurements, FFR and IFR. In this paper, you see the results of just by judge 15 minutes after the last dilatation. It seems, at least for IFR, this is not so significant difference between 10 and 15 minutes like it was for FFR. However, this proposal, 15 minutes, seems and sounds very good. The other problem which we can solve also with IFR is just to take into consideration some subgroups of patients, taking into account that this generally cutoff criteria 0.89 is not ideal in a certain clinical scenarios. If you look at the smoking habit, hypertension, reduced EGFR, localization left main LAD, non-STEMI multivessel, you see that it differs from 0.89. So it's not much, but still, with this approach, we can increase so-called positive IFR measurements in the group of multivessel disease. It matters in terms of bigger concordance also with FFR. Just at the end, I would like to share you additional information from DEFINE PCI, which showed us that IFR measurements give us possibility to assess the results of stent implantation, and in 1/4 of the cases, the first measurement showed us that the final IFR was below cutoff criteria 0.89, and it occurred mainly in a diffuse pattern of atherosclerosis. We should take it into consideration. This is the true that based on IFR pullback maneuver, we can assess the localization of the stenosis, and here you can see the distribution: 30% for pressure gradient proximally to stent, 30% for residual in stent, and 30% distally to stent. It's worth to be tested at the end of the procedure. You can solve it with optimization of the procedure or additional stent implantation. In terms of prognostic value of IFR, we have to wait for final decision. However, we see that the proposal of 0.95, it's something, but it's not so easy to achieve so high value.